Welcome to the Wisconsin Antibiotic Stewardship Targeted Assessment for Prevention conference call. My name is Karen and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. I will now turn the call over to Deanne Richards. Deanne, you may begin.
Thank you, Karen. Good afternoon. My name is Deanne Richards, and I'd like to welcome you to today's webinar, the WiTAP, or also known as the Wisconsin Targeted Approach to Prevention Antimicrobial Stewardship Program. It's presented by the Wisconsin Hospital Association and the Lake Superior Quality Innovation Network, also known as LSQIN. Lake Superior QIN is comprised of three organizations: MPRO in Michigan, Stratus Health in Minnesota, and MetaStar in Wisconsin, to support the Centers for Medicare and Medicaid Services priorities for healthcare quality improvement. We know that all healthcare organizations are working on making quality improvements in your facility to prevent and reduce healthcare-associated infections, support the culture of safety, and improve communication. We hope what you learned today will help you to be successful in these efforts. This session is being recorded and will be available in about 2 weeks. The PowerPoint handout is available in the initial logon screen on the left-hand side of the section titled Event Materials. Enter your password being WiTAP with a small I into the section to access the document. Please note these documents are in PDF. Your actual links you received this morning by email are active, and you can download these documents that we're going to share in our toolkit in Word as well as Excel. We'll remind you how to access this and our recording at the end of the session. All lines will be muted during the webinar. We're hopeful to have a question and answer at the end of the session, so please make notes of any questions that come up as you listen and we'll respond to the group. Just so that I know that you're fully present and engaged, feel free to share your thoughts in the chat section. With that, we'll start today's presentation. Our first speaker will be Jill Hansen from the Wisconsin Hospital Association.
Great, thanks, Deanne. Hi, everybody. So I just really wanted to go over the objectives for today. Wanted to know on today's call, we want to make sure that by the end of today's call that you're going to have a better understanding of what the landscape is around antimicrobial stewardship as it pertains to Wisconsin. Also going to share with you the tool that was specifically developed by hospitals in Wisconsin, so we're very excited for that. And it's what we've named as the Antimicrobial Stewardship Targeted Assessment for Prevention, or TAP strategies, which include a TAP report, a TAP tool, and TAP resources. And then lastly, we want to provide you with kind of the next step. So what do you do once you get all this information, and then how do you take this back to your organization and move forward with your Antimicrobial Stewardship Program? So really, in order to do that, I really wanted to provide you with a little more background of kind of our status of our state. So we want to look back at 2014 and 2015. So in 2014, we actually established an Antimicrobial Stewardship Program. And what we did was we kind of partnered between our two organizations, between the Hospital Association and MetaStar. We also were fortunate enough to have 20 of our hospitals participating in this as part of our pilot group. And what they were able to do was, those that were involved, we did various sizes of organizations. So it wasn't just big systems, it wasn't just critical access hospitals. What we wanted to do was be able to create a tool that was not only usable for organizations that were big, small, any organization would be able to use this to assess their antimicrobial stewardship program going forward. So what we did initially was we utilized the CDC core elements as sort of our starting point. While the CDC core elements it's a great start, what we really did was we just added meat to those bones. And so we received input from the hospitals on those core elements. And then it also gave us an idea of where we really wanted to identify where organizations struggled. So what we did was we noticed that the biggest hurdle is really how do you identify where do you start with your antimicrobial stewardship program. So the tool that was developed then really allows an organization really to identify those gaps and the opportunities within their organization that will help them improve and enhance their antimicrobial stewardship program. So using a series of teleconferences, we really utilized the suggestions from our participating hospitals along with the Pharmacy Society of Wisconsin. We actually developed a tool. We had it utilizing, we talk about small tests of change and improvement and doing the PDSA cycle. So we actually did that with our group. So we practice what we preach. So we developed the tool, we reviewed it, we made enhancements. We went back to the drawing board after the first iteration and then redid it. Had our teams pilot this along the way. So the tool that you're seeing now has been what we feel has been vetted enough times that we're confident to say this is a tool that we want to push out to everyone, and which is why we wanted to have the webinar today. So one of the things that we wanted to be able to do was really to understand what the landscape was in Wisconsin. So in January, we had a webinar around antimicrobial stewardship, and it really was to lay out sort of our next steps for 2016 and to give you kind of a precursor of that the tool was coming. But we really wanted to get where hospitals were in terms of their antimicrobial stewardship practices in their organization. So excluding the people that didn't have an opportunity to answer that polling question, where we saw the biggest spike with the responses was that organizations had limited experience with antimicrobial stewardship programs, and some organizations may not have had any experience with an antimicrobial stewardship program. So we knew that whatever we designed with this group had to be something that an organization could fully understand as they begin to look at that tool. So in terms of the Wisconsin landscape, what we also asked was what would an organization's biggest hurdle in terms of starting an antimicrobial stewardship program in their organization. What we typically hear, and this usually happens with organizations, is there's so many competing priorities. It may not be part of our strategic goal, and so that's really the balance of how do we start doing this. Knowing that things like Joint Commission beginning 2017 is actually going to hold organizations accountable for this, we wanted to make sure that we were setting up organizations to be in the best position possible as they rolled into 2017. The other things that we saw the struggles with was really not really sure who would actually lead this within our organization and having that leadership support. So you'll see some of the tools that we've developed. In terms of the prescribing approaches, again, we really wanted to have a better understanding of what was happening currently in the state. And, I think that knowing what your prescribing practices and being able to monitor that and provide that information back, those are key things when you start your antimicrobial stewardship program. So what we saw when we did this in January was 31% of those organizations didn't have prescribing approaches in place. So again, being able to do this assessment tool to really identify where to start within your organization. The prescribing approaches may not be your initial thing to start, but it gives you an idea of where you're at. It also allows you kind of where everyone else is in the state. So again, we know that the prescribing approaches may not be at the levels that we wanted when we took this. So then really what this next slide does is it shows you for the hospitals that were part of our pilot for this, this is really their overall results that they saw when they took the tool. And as I walk through this, as Jan and I walk over the tool, we'll explain a little bit more how the tool is laid out. But one of the components of this is a summary report. So you can see the goal is when you take the assessment is that after you take the assessment, it'll auto-calculate this results for you. But the goal is really to be able to rank 70% or higher in three of the areas that we've identified in sort of our bigger buckets for either the infrastructure, your policy procedure, or your education by the end of 2016. So knowing that those are a slight stretch goal for organizations, but knowing that for some of you those Joint Commission requirements for an antimicrobial stewardship are just around the corner, we thought a 70% goal is reachable by organizations. And again, it may be little things like tweaking your education policies. We also wanted to make sure that when you filled out this assessment tool that you get credit for some of the work. So maybe all of these components aren't fully implemented. It still gives you credit for some of the pieces that were done. So we really wanted to give it a better picture for you of really the true representation within your organization. So now I'm going to turn it over to Deanne, and she can share a little bit more about how we created the TAP report.
Thank you, Jill. So the very first thing that we look at, a typical PAP assessment using the Targeted Assessment Prevention Approach, which was developed by the CDC, is normally the infection preventionist would turn to her computer, log into the National Health and Safety Network database, and run a pre-prescribed report. Well, that is not an option for us for antibiotic stewardship. So Jill and I were putting our heads together of how could we actually pull data and use that in a comparison and make it useful for you. And what we came up with is that we actually pulled all hospitals from 2014 and 2015, pulled their annual surveys. So for the pharmacists on the call, that means every March the infection preventionist puts in or the administrator puts in very specific information such as how you're using the test, but there are very specific questions related to antibiotic stewardship. What we did with that is we did a little analysis of the data to see how we compared in 2014 to 2015 and what that difference was. I do want to point out there is an asterisk there. That's just a reminder that's one of the CDC core elements. So those are things that we do want to ask that you do keep that in mind. So the highlights I wanted to share is that the written statement of leadership support increased by 67%. That's really core for us, because per the experts I've heard speak on antibiotic stewardship, that is one thing you must have in place. You have to have a strong leadership support. It's even more important than having money or FTE allotted, because without the administrative support, individuals as well as organizations have a hard time moving forward. The other aspect I wanted to highlight is the leader responsible for antibiotic stewardship program. It increased by 27%. But also notice that single leadership decreased as we saw a significant increase in co-leadings across the state. Although we saw an increase in the policy for antibiotic indications, we also saw a decrease in the monitoring of the policy. Jill's one of those that, she's a data person. She wants to see the monitoring and she wants to see that you're actually following that and utilizing that. The other one is to notice that the antibiotic timeout increased by 82%. That is wonderful. That's exactly the direction we want to go. That actually little mini timeout is basically at 24, 48, 72 hours. Somebody takes a peek and looks at the whole picture of the patient. What are the signs and symptoms? What are the lab results indicating? What's the antibiotic we're using? Does this all line up, or do we need to make adjustments for that patient care? The other items that we wanted to look at was the monitoring use of antibiotics is a core element, and we did have a 31% increase in the year. But as you can see, the defined daily dose decrease with days of therapy increased. We say that it's nice to have that upswing in antibiotic use monitoring as shared in the 39% increase, and the feedback to improve was also increased by 23%, and education on how to improve the antibiotic use increased by 29%. Overall, looking at all the information, this resulted in a 42% of the hospitals in 2015 meeting all core elements, which is a nice increase from the only 29% the year prior. So what did we learn? Well, we did find that collaboration, even when we don't have tools done, but talking about it, seeking information, finding out what's working for different organizations, that does result in us having a better understanding of what's going to work best for us here in Wisconsin for antibiotic stewardship. It also resulted in us adding additional questions, reformatting the original documents, taking into consideration the size of hospitals as well as their resources, and overall how to make a much better tool. As we were working along, feeling really good, ta-da! Joint Commission puts out the Accreditation Standard late in 2015, and the standard has 8 performance elements. Just to let you know, yes, they have been accepted, and all of the elements we're going to review now will be needed as of January 1st, 2017. Even before we even talk about these elements, I want you to wipe that sweat from your brow and know that all of these elements, as well as the core elements from CDC, are already built into this tool. So the first element being leaders establish an antimicrobial stewardship as part of an organizational priority. Some of those commitments can include accountability documents, budget plans, infection prevention plans, performance improvement plans, strategic plans, and the use of electronic health records to collect antimicrobial stewardship data. The second element being that the hospital educates staff and licensed independent practitioners involved in the ordering, dispensing, administration, and monitoring, and it includes resistance as well as practices for antimicrobial stewardship. They do denote on hire or granting of privileges and periodically thereafter, so you get to define that periodically and what that means, and it really is based on your organizational needs. Well, to know what your needs are, you need to be collecting data and monitoring. The third element is that there's education to patients and their families as needed regarding appropriate use of antimicrobial meds, including antibiotics. And just know, we're going to show you in another tool that we've actually incorporated education tools we've already found for you that you may want to look at, adapt, adopt, or say, nope, this one isn't going to work. Element 4 has that you have a multidisciplinary team with the following members. And notice that it doesn't say only these members, it just says the following. It includes infectious disease physicians, infection preventionists, pharmacists, and practitioners. Please note, you don't need full-time staff to do this. They do say that part-time or consultant staff are acceptable as members of this team, as well as telehealth staff are acceptable members of the team also. In the element 5, this should look a little bit familiar to you if you're familiar with the Joint Commission, because with the CDC core elements, because they're all in there. So leadership commitment is dedicating necessary human, financial, and information technology resources. Accountability appoints a single leader responsible for program outcomes. And we want to have that person be experienced with successful programs. And it does show from our data as well as from other sources that physicians can be indeed effective leaders for this position. Drug expertise, appointing a single pharmacist leader responsible for working to improve the antibiotic use. Action, being implementing recommended actions such as systematic evaluation of ongoing treatment needs after a set point of initial period. That's just another fancy way for saying take that antibiotic time out. Tracking, monitoring your program, which may include information on prescribing and resistance program. Reporting is gathering that information on your program, which includes use, resistance, and providing that information to your physicians, your nurses, and other relevant staff. And finally, that last one being education. So educating your practitioners, your staff, your patients on your program, and including information about the resistance and optimal prescribing. So basically, all of those again are within this toolkit for you. It goes on for element 6, which you use your antibiotic stewardship program having an organization-approved multidisciplinary protocol. Those could be antibiotic formulary restrictions, assessment of appropriateness for antibiotics for community-acquired pneumonia, assessment of appropriateness for antibiotics for skin and soft tissue, also for urinary tract infections, care of patients with C. difficile, guidelines for antimicrobial use in adults, as well as pediatrics, a plan for parental and oral antibiotic conversions, pre-authorized requirements for very specific antibiotics, as well as the use of prophylactic antibiotics. And number 7, we need to collect, analyze, and report out that information. And that may be including what your program is doing, including your prescribing patterns or your overall resistance patterns. And then element 8 is taking action on all of that information. So at this time, I'm going to hand it over to Jill, who's going to start introducing each one of our tools within our kit.
Great, thanks, Deanne. So what you see in front of you is really what we've come up with in terms of a milestone and a timeline. And what we wanted to be able to do was share with you as we provided this tool we started with our APIC chapters in the state, as well as our design team members. And the feedback that we got from them as they looked at the tool, they said, this is great, we're just wondering if there's any way that you can kind of provide us with information about how do we get started. So what are some things that we want to tackle within the first 30 days, the first 60 days, the first 90 days? So again, this, as you see on the screen, and so some of these may get a little bit small, but as Deanne mentioned, you would have received the handouts prior to the webinar today, so go back and click on those and you can see it a little bigger screen. But again, we wanted to make sure that hospitals not only are able to take the tool, complete that with their team, but then really what do they do with the next step? So what we did was we developed a 30, 60, 90-day milestone and timeline. So this 3-month document lets you plan your meetings, utilize the tools, and develop a plan specific for your organization with time to make improvements before 2017 occurs. And we know that's right around the corner too. So it provides you with agenda items and assessments. So in the first 30 days, what we're recommending, based on what's in the tool, is really to establish your antimicrobial stewardship multidisciplinary team, set up your regular meeting date and time, and then be able to complete the following. So we want to establish who's going to be leading that for the program outcomes, appoint your single pharmacist leader. So if you have a pharmacist in your organization, if you have one that you can do off-site that can come on, that you can consult with, again, really trying to make it flexible for your organization, but really identifying kind of the key people. Look at that current status TAP report so Deanne shared with you. So that report, what we have for you as you go through and see what it was for 2014 and 2015, your team then will then fill that out, a yes-no response. It'll give you an overview, a big picture. Also within that 30 days, we're going to talk about that assessment template. Review the phase 2 steps, just review the steps. And what we want to be able to do is to say, okay, based on that, assign members on your team 2 different sections of the Antimicrobial Stewardship Implementation Guide, really to review and really make the recommendation. So it's really, this isn't just a one person. So if you're hearing this as a pharmacist going, I have to lead this, it's really about co-leading this, and it's really about having the team and being able to designate other individuals on the team to help with that. So really what we want to make sure is the first 30 days is you're really reviewing all of the tools that we're providing you, and you're kind of establishing what our next steps are going to be. So then for the next 60 days, so we have the 60 and the 90 days, in terms of that 60-day mark, so in terms of your antimicrobial stewardship team meeting, we want to really, based on the results that you had, having individuals on your team report back on potential actions based on that implementation guide that we are going to share with you. We want to have you complete that matrix activity that we're going to have you complete, or we're going to go over in a little bit. And then really it's really for you as your team to really decide what do we want to start working on. And then we have another tool that allows you to really identify, if we know what we're going to work on, how do we actually drill that down to a specific item that we're going to use, and this becomes what we're going to test, and what we call this a small test of change. And then really it is, as we're thinking forward, in terms of our education plans for staff and patients, how do we start to build that into our plan as you move forward? So not saying that you have to develop that all right away, but you have to be thinking about how you're going to implement that. So then really at your 90 days, it's really, okay, let's come back. Let's look at what we actually started, what we focused on. Do we have a chance between that 60 and 90 days to actually test out and actually start work on that first item that we started to look at? So are there different things? Did we pick a protocol that we just needed to update one of our protocols? So can we come back to the group and actually have a conversation about that? Do we need to modify any of those education plans because we started talking about them at the 60 days? Is there anything that we can modify going forward? And then really it's continuing to say, okay, so what are our next steps for the 120 days? So again, it's really meant to be is really something to help you to stay on task and really to identify for the team what are the asks that you have for that team. So now I'm going to turn it over to Deanne.
So I'm going to highlight what's the second tool in your toolkit, which is the TAP Current Status Report. One of the first items that you'll complete as a team for your TAP Current Status is this report. You'll notice that below the 2015, there is a 2015 facility response with choose an item. This is actually a drop-down menu when you actually open it in a Word document versus the PDF that you may have in your hand right now, and you select yes or no. This allows the organization to compare themselves to the rest of Wisconsin organizations both for 2014 and 2015. It's meant to be completed by your team and then shared with administration, the Infection Prevention Control Committee, as well as your Pharmacy and Therapeutics Committee. In one document, it allows your organization to benchmark and gain support for that Antibiotic Stewardship Program. And then, Jill, why don't we talk about our next tool?
Perfect. So the next tool that we have is really a three-part document, which is in an Excel spreadsheet. And so that first tab really it gives you the instructions on how to complete the tool. And so it gives you a little bit about the history behind it and really the intention of completing that tool itself. So within that, the instructions is it allows you, as it goes through kind of the purpose of the tool allows you to determine where your antimicrobial stewardship is currently at compared to the best practice. It also incorporates the CDC core elements and the upcoming Joint Commission requirements, as Deanne mentioned as well. So as we move forward, the second tab within that Excel spreadsheet, and I would recommend if you have the opportunity to actually, when you meet with your team, pull it up on a computer and have that. When you print it out, it gets a little small because there is a lot of information, so it might be a little easier for your team to actually have that up on a screen. So really the second tab is what we call kind of the meat to everything, and it really allows you to it's the screening questions. So we have 8 categories, and as a group you're going to answer if you have the element in place across the entire organization by placing a 1 in the yes column, either in or only in certain units, just starting, and no. And so you'll notice that when you click into the answer column, a prompt will appear to remind you how to indicate the element is true. And we encourage your team to complete this section prior to opening the third tab. And the reason why that's important is as you are entering all of this information and answering this information as your antimicrobial stewardship team, we can't stress that enough because what one person might think is happening, we really want to get the collective thoughts on the entire team to really to see what's going on. And where we mentioned, as you complete this, the third tab is actually calculating the results. And so that is, when we showed you earlier, those are really the results. So as you're answering this, it will give you a summary of, for each of those 8 sections, it will give you a summary of where you're ranking up to that. The goal is to get to that 70% higher. So that you can see across the board where you're doing really well and where there's the opportunity that you might have to go, this is where we really need to start. So if we're looking at our leadership support and accountability and we see that that's lower than everyone else, that may be the area that we really want to start. So again, we also wanted to be able to provide you with a tool that would correspond with each of these general sections. So I'm going to hand that over to Deanne to talk a little bit more about how the utilization guide ties with the TAP tool.
So as Jill mentioned, our next tool is the Targeted Assessment for Prevention Utilization Guide. And that's really a fancy term to indicate if you have questions, we have answers. We have compiled 21 pages of electronic documents with descriptions and hyperlinks, which are organized into the 8 categories of the TAP assessment. So let's use that example again of the patient and beneficiary information. When you actually have the true Word document open, by going to page 10 of that document, you can reach the education section, and that section is not one page, multiple pages long. Out of all of those entries we have there, you're going to find 8 sites with pre-made patient education, as well as additional sites which contain information on the importance of patients being aware of the antibiotic use. As every organization has different needs, we recommend that after you know what your TAP assessment results are, you look at each category in the guide and divide out between your team members who's going to look at the specific resources and bring the information back to the next meeting. This will allow your team members to share the information back with the team, as well as allows the team to hear all the information and decide, are you going to adopt it? Are you going to adapt it? Are you going to decide to abandon it and go on to another resource?
So now the next part is once you complete your assessment tool and you have the results and you go, okay, so what are we going to focus on? We identified that we know some areas that we think we want to start on, and what we wanted to be able to do was to go, okay, so now that you've completed the tool, what are the next steps? So we've created sort of a phase 2, and we've identified it into a number of steps. So what we really want you to do is to say, as your team, you're gonna print off that summary report. You're gonna look at which of the areas that you're below that 70%, and of those, let's look at, to say, as an organization, which are the areas that we want to focus on. And then what we really want you to be able to do then is to begin brainstorming and to identify, okay, so here's where we've identified, where do we want to do, and how do we know what we want to focus on. So what we wanted to do was, with that, is provide you with some brainstorming instructions, because some individuals in your organization may not have an idea how to do the brainstorm. So what we wanted to do was provide sort of a decision matrix for you, and then what you allowed you to do was the teams then would for each of the topics that you're going to focus on, you really narrow that down to a specific topic, and then you start to brainstorm how do we either implement this or improve the practice that we have in place. So having the input of the team and actually sitting down and being able to go, you know what, we're going to do this, whether easy to implement, difficult to implement, and then we're going to go low impact to high impact. You actually draw that on a board, and then you just have people just really get their ideas and put them on. You write them all down, and then you start to put them on this decision matrix to really identify what are some things that are what we call kind of the low-hanging fruit that would be easy to implement and quick wins for your organization, and what are some things that really you recognize that you need to do, but they may require additional resources. They may require you to talk to leadership because it may be a cost issue that you need to incorporate within your organization. So it gives you the idea, it gives you the ability to actually see where do we want to focus. And then again, step 6 is really look at that and then identify which are the ones that you want to focus on and really within the next 3 months. And then as you're creating that, how do you go about taking what's on that sticky and creating a specific design? So we encourage teams to remember that if you have best practices which are occurring in some settings, such as your ICU, these items may be easy to implement with other high impacts with other units. And then after decisions are made as to the best methods for improving by the team, this then is recorded in the design for small tests of change document. So Deanna, if you want to go to the next slide. Yep. So then what we want you to be able to do is think small. One of the things that I think organizations, they get very excited to want to start, and so they pick a big component of this, and what we really want to say is actually just take a small bite. Find something really small, and you may think, well, that's really too easy. But to get people on board and to start moving this along, it starts to get the buy-in. And so again, it's really utilizing the tool and beginning to put the information in there. So let's go for an example. You have a process in place in the ICU which limits certain antibiotics to certain prescribers. How do you know if this process is working well? So you may need to do an audit, the practice first in the ICU, and once you have that data and you compare it to the expected practice, you can then decide, do we want to adapt? So we may need to make some changes in our practices before the team audits a second time. Do we want to adopt the practice on another unit, such as an intermediate care unit, without the need to make the changes because we actually did enough small tests of change that we felt that it was ready to go? Or as we started to go through this, we really realized this really wasn't the approach that we wanted, so we want to abandon that. What you're able to do then is really document kind of the processes. It allows your team then also to know who's involved in what, and it allows for the people that are actually doing some of your testing, they know their ask. So again, going back to that example, if you adopt, how do you begin to adapt this and think about rolling this out in other units? So when we talk about rolling this out, we actually are saying start small. Now some of you might be smaller organizations and you say, you know what, we're going with it. So again, take it in chunks that it work for your organization and recognize systematically as you move forward. If you start small, how are you going to roll that out for your organization? And then how do you sustain this as you roll out this antimicrobial stewardship program? So again, when you're thinking that initial meeting that you have with your team, we want to make sure that you're thinking long-term. So how do you sustain the great things that you're beginning to implement, and how do you keep that going?
So our last item that we have in the toolkit actually came out of the fact, after we did our initial presentation, that individuals started asking, can you just give us a document that we can document leadership support on? So this Word document is based on the National Quality Forum Antibiotic Stewardship Playbook, which was released earlier this summer. It allows the organization to add and remove elements, and it has 3 levels. The basic level assists facilities who are just starting out with work on antibiotic stewardship programs, and it helps them determine what aspects of support are most beneficial. The intermediate level can be used by organizations who have already started this work but are still working towards that improvement. Where the advanced level is for organizations who have been working on antibiotic stewardship for many years but want to continue their efforts. Just keep in mind, your organization can remove items from any level, and you don't have to do everything that's on this sheet. It just gives you a way to know this is some of the things we can do, as well as you can add more information there about what you're doing. We know that leadership support is crucial to having a successful program, and having a document which all are in agreement for support will make your job a little bit easier. Although this does conclude our webinar, I wanted to remind you that all the tools we discussed are available on the following links, and even on your handout page, the link was listed there for each and every one of those. We encourage you to follow those links, pull off copies, and save them to your own computer system. Jill and I are asking that facilities do share back with either Jill or myself the antibiotic stewardship TAP assessment template. That will help us decide what our next steps will be here for Wisconsin. And we're hopeful that from those returned assessments, it will help us better understand how we can support your organization as how we can continue to support the patient safety. At this point in time, if you have any questions, we'd be happy to take them. Karen, can you remind our participants how they can ask a question?
Thank you. We will now begin the question and answer session. If you have a question, please press star, then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. There will be a delay before the first question is announced. If you're using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star, then 1 on your touch-tone phone.
Don't worry if there's silence on the line. From Jill and I presenting this to our work group as well as the 4 APEC chapters, we've become accustomed to silence after we get done. We realize it's a little bit overwhelming when you look at everything within the toolkit as well as what we've set up to move forward.
And we have no questions at this time.
Okay. And I am also not seeing any anything in the chat section either.
Oh, pardon the interruption. It looks like we do have somebody. We have Kathy Noe. Go ahead, your line is open.
The question that we have was on that assessment, Dan, that you wanted us to complete. Do you have a deadline for that?
We do not. The sooner the better. We're hoping that all of Wisconsin can continue to move forward, and we're hoping that you're able to follow the 30, 60, 90-day process, which would mean that if you can have it done within the next 2 months, that would be wonderful.
Okay.
Because, Jill and I don't like to sit around twiddling our thumbs hoping that we're supporting you. We like to be helping any way possible.
Okay, thank you.
You're welcome, Kathy.
And we have no questions at this time.
And I'm just checking chat, and I am not seeing any questions in chat either. I do see in the Q&A section, I do have some questions, so let's go ahead and try to answer those. In elements 2 and on, are these only applicable to critical access hospitals? We tried to develop the form so they apply to all hospitals. So there shouldn't be anything that should be specific or you feel that excludes you from this, because from what we found from doing our studies, it didn't create a separate exception or expectations for a critical access versus an acute care hospital. The next question is, who is expected to lead the meetings? That is actually up to your organization who's going to lead the meetings. From working across the state, we've heard where IPs have been appointed to be the lead on this. We've heard from working with the Pharmacy Society that pharmacists have been given the lead on this. Each and every organization will need to make the decision of who will be leading this effort.
And you'll notice that when we talked about the annual survey out of NHSN, we're seeing an uptick in actually co-led meetings between a physician and a pharmacist. So that's just something to keep in mind as well.
Is it required that programs have an infectious disease practitioner? That's actually an excellent question. It does not require that you have an infectious disease practitioner. Let's say you're a smaller organization and you do not have an ID doc on staff, but yet you have that element 4 in Joint Commission that wants that infectious disease to be part of your multidisciplinary team. If you have a part-time or consultant, I would encourage you offering or asking that they consider joining your team. So the staff, that ID doc does not need to be full-time or present at all times, but we do encourage you to include them as part of your team. They're also, if it's a consultant, they can actually bring a wealth of information what's going on in other organizations, which I always find very helpful to find out what works or doesn't work or where another organization is moving towards. We're just looking to see if there's anything more coming up. At this point in time, I'd like to thank everybody, and we'll conclude today's educational session. Remember that the PowerPoint presentation is a WebEx handout. It's under your event materials. And the recording will be available in about 2 weeks, and it will be posted on www.lsqin.org/initiative/HAI. If you haven't had a moment, please go ahead and complete the evaluation form. That will help provide us with feedback as we will continue to work towards providing quality events. Thank you for spending time with us today, and we are very excited for the number of participants that we had on the line today. But feel free to contact Jill or myself if you have any questions or concerns. Thank you.
Thank you.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.